Hello, everyone. Thank you for joining us today for our webinar entitled Breaking Down Barriers to the Sharing of Behavioral Health Information. My name is Liz Jones, and I am today's moderator. Before we begin, I have a few housekeeping items to touch on. We will be keeping everyone muted during today's presentation. If you have a question, please type it into the questions box in your GoToWebinar interface, and we will address it during the Q&A. Because of the large number of attendees for today's webinar, we may not have time to answer all of the questions. If we do not address yours during today's broadcast, you will receive an answer through email. Also, the slides from today's presentation and a link to the recording of this webinar will be available soon on our MCEDA website at www.mceda.org/webinars. And in the near future, the recording will also be available on the MDHHS website. By participating in this Alterum Institute webinar, you are automatically agreeing to authorize recording of the audio and visual content presented during this event and consent to subsequent use of the recording in the public domain by Alterum Institute. This recording may include questions and responses provided by you during the live event. This recording will be made available after the conclusion of this event as part of the Alterum Institute webinar archives and will remain available indefinitely. If you do not wish to consent to the recording, please do not join this event. Alterum Institute webinars are intended solely to provide information to the public. The views and opinions expressed as part of these webinars do not necessarily state or reflect those of Alterum Institute. It is not intended, nor can it be relied upon to create any rights enforceable by any party in litigation or to endorse any other organization or service. With respect to these webinars, neither Alterum Institute nor any of their employees makes any warranty, express or implied, including the warranties of merchantability and fitness for a particular purpose, or assumes any legal liability or responsibility for the accuracy, completeness, or usefulness of any information, services, products, or process disclosed, or represents that its use would not infringe privately owned rights. Our PHI consent tool has been prepared for educational purposes only. Nothing in the consent tool is intended as, nor should be relied upon as legal advice. Any party that is contemplating the use or disclosure of protected health information for any purpose is encouraged to consult with its legal counsel. Today's presenters are Christy Avery and Nick Priss from Alterum. Christy is a client service manager for MCEDA in Alterum's Center for Appropriate Care. She has been working on quality improvement for 7 of the 31 years she has been in healthcare. In addition to working on the PHI consent tool, her primary focus of late has been teaching provider offices rapid cycle quality improvement, change management, and workflow analysis in order to better use their health information technology with the goal of improving patient care and maintaining optimum reimbursement in the changing paradigm of payment for quality. Christy has a bachelor's degree in psychology from Eastern Michigan University. Nick received his bachelor's degree in psychology from Duke University. Upon graduating, he was selected to the Challenge Detroit Fellowship Program and provided management consulting services to a variety of nonprofit organizations, including community mental health agencies throughout Metro Detroit. He gained clinical experience as a qualified mental health professional at Stonecrest Center, an inpatient psychiatric hospital on Detroit's east side. Upon graduating with a master's degree in social work, he pivoted to a part-time mental health clinician utilization reviewer role at Stonecrest Center, along with becoming a behavioral health care consultant in Alterum's Center for Behavioral Health. This webinar, part of a new learning series from Alterum, is made possible by the Michigan Health Endowment Fund and is designed to help the healthcare industry navigate the complexity of consent and confidentiality regulations around the exchange of physical health information and, most importantly, behavioral health information by introducing a brand new PHI consent tool. This new tool uses the most up-to-date legislation to guide you in determining whether consent is necessary to share protected health information, or PHI. We will be sharing a direct link to the PHI consent tool at the end of this presentation. In the forthcoming months, Alterum will also be offering training videos to introduce you to this brand new PHI consent tool. Following this presentation, Christy and Nick will take time to answer any questions posed by the attendees. We will be asking today's audience a few polling questions. The first one is, have you struggled with knowing when consent is necessary for releasing various types of PHI? You can use the radio buttons to choose your answer. We will give everyone a few moments to submit their responses. You can now see the results on the screen, and I will turn this presentation over to Nick.
Thank you, Liz. It looks like most people had answered yes to that first polling question, so 66%, 30% had said no, and then 3% had said not applicable. Okay, so with that, I'd like to start today's webinar with an overview of the agenda and what we plan to cover, and hopefully what you guys have reported in the first polling question will be addressed throughout today's webinar. So we'll go over physical and behavioral health legislation, substance use disorder legislation, use of consent forms, the PHI consent tool, and how to increase sharing with health information technology. Now I'd like to highlight why the Michigan Health Endowment Fund funded Altarum to complete this work and what the overarching goal of this project is, which is to break down the unnecessary barriers to sharing behavioral health and substance use disorder protected health information across the state of Michigan. Also, keep in mind that the healthcare industry is the most regulated industry to begin with, and even more regulated when we're talking about behavioral health, substance use disorder, and domestic violence matters. And moving forward, I'll refer to substance use disorders as SUD. But the other thing to keep in mind here is that the complexity of this work makes it very nuanced, and as a result, we understand how frustrating this work can be, but we've also attempted to simplify the process of when and how you can share behavioral health, SUD, and domestic violence protected health information as reflected in the PHI consent tool that we'll be covering. So today's presentation goals are focused on the following. It's to develop a better understanding of state and federal laws that affect the sharing of behavioral health, SUD, and domestic violence PHI, having an increased familiarity of MDHHS 5515, the Behavioral Health Standard Consent Form, and using the PHI consent tool more easily, and then also developing a greater awareness of how one might leverage health information technology to increase sharing of behavioral health PHI. Also, keep in mind that today we'll be providing a high-level overview of this information, but in the near future, we'll be releasing in-depth training videos on all the topics presented in today's webinar. Now I'll focus this portion of the webinar on key state and federal legislation that affects the sharing of behavioral health, SUD, and domestic violence PHI. Now, having said that, let's jump into some key state and federal legislation that affects the sharing of physical and behavioral health PHI. It's important to note that what I'm about to cover in this slide does not apply to the sharing of SUD PHI. However, I will be covering that information in some later slides. Okay, so as you can see in this Venn diagram, we've attempted to provide a visual of how the Michigan Public Health Code and HIPAA align, which means physical health information can be shared for the purposes of treatment, payment, and healthcare operations without an individual's consent. We've also attempted to show how the Michigan Mental Health Code and HIPAA generally align with the exception of one word, which is coordination of care. HIPAA includes coordination of care under its definition of treatment, whereas the Michigan Mental Health Code privacy provisions include both treatment and coordination of care, but specifically exclude the term healthcare operations. So with that said, most importantly here, I'd like to highlight the Michigan Mental Health Code, which again generally aligned with HIPAA regarding the sharing of behavioral health PHI in 2016 with the passing of Public Act 55-9, which permits providers and health plans to share behavioral health PHI for purposes of treatment, payment, and coordination of care. Now we'll pivot the discussion to address the exchange of SUD PHI. And in the great state of Michigan, if you're a licensed covered entity providing SUD services, chances are you're regulated by both Chapter 2A of the Michigan Mental Health Code and Title 42 Code of Federal Regulations Part 2, or more commonly referred to as Part 2. So you may be asking yourself, what does that mean? This means if you are a covered entity licensed to provide and actually provide SUD services in Michigan, then MDHHS 5515, which I'll now just refer to as 5515, also known as the Michigan Behavioral Health Standard Consent Form, or an equivalent form that meets the privacy provisions outlined in said legislation, is required, unless the disclosure of the SUD PHI falls under any one of the following statutory exceptions that we have listed on this slide. And the first one we have there is medical emergencies, de-identified information for research, de-identified information for financial audits, de-identified information for program evaluations, and then specific court orders. So now let's cover MDHHS 5515. Again, I'll be referring to it as 5515. So what is 5515? Well, as previously stated, 5515 is the Michigan Behavioral Health Standard Consent Form, and it was developed by the Michigan Department of Health and Human Services in response to Public Act 129 of 2014. And I think it's really important here to highlight the history behind why Public Act 129 of 2014 was promulgated. And with that said, prior to Public Act 129 of 2014, providers were often developing their own consent forms to share behavioral health and SUD PHI. And the differences between forms made sharing such protected health information across healthcare systems difficult for both individuals and providers. So in order to address that problem, the Michigan legislature had passed Public Act 129 of 2014, which then directed MDHHS to create a standard consent form for sharing behavioral and SUD PHI. And really, the overall or overarching goal, rather, of Public Act 129 of 2014 and 5515 is to make the consent process simpler for both individuals and providers in the state of Michigan. Now, having provided all of that history and background information, let's go over again when the use of 5515 is required. So for the first point that we have here, we have listed for behavioral health or mental health services for purposes other than treatment, which generally means the provision, coordination, or management of healthcare and related services among healthcare providers. Also for payment, which encompasses the various activities, but is not limited also to the different types of activities healthcare providers do to obtain payment or for reimbursement of their services and or for health plans to obtain their premiums. And then lastly, we have coordination of care, which again technically falls under under treatment per HIPAA, but here it really refers to the referral of a patient from one healthcare provider to another. And then the second major point that we have here is for substance use disorder services for all diagnosis, referral, and treatment. So then this, of course, warrants rehashing the exceptions to using 5515, or in other words, when use of 5515 or equivalent is not required to share said PHI. But I'd like to hone in on the first exception we have listed here, which is medical emergencies, because there tends to be a lot of confusion with this exception given the current opioid crisis. Now, the other exceptions are relatively straightforward and self-explanatory. So let's play out a hypothetical here with medical emergencies rather. Let's say you're an emergency room physician and EMTs brought in an unconscious individual following an opioid overdose. A question that may come up is, can you alert that person's family? Well, the answer is yes. You can notify the family as permitted by HIPAA, just as you could for any other medical emergency care. And also, as an emergency room physician in a hospital, neither you nor the emergency room is subject to Part 2 or Chapter 2A of the Michigan Mental Health Code.
We have another polling question. This one is, does your organization regularly use the MDHHS 5515 consent form? We'll give everyone a few moments to submit their response. Thank you for your feedback. You can now see the results of that question on the screen.
Okay, it looks like most people had said yes, they do use MDHHS 5515 in some capacity. And to be exact, that was 54% of you had said yes, 11% had said no, 27% said I don't know, and then 8% said not applicable. All right, so lastly, I'd like to wrap up my portion of the webinar by briefly covering the nuances of domestic violence legislation. So if you are a covered entity receiving federal funding under any one of the following pieces of domestic violence legislation that we have listed here, which is the Family Violence Prevention and Services Act, the Victims of Crime Act, and the Violence Against Women Act, and have provided someone with services for domestic abuse, sexual assault, and/or domestic violence-related crimes, then a specialized consent form is required. So in other words, you can't use 5515 if you are an entity receiving funding under one of these pieces of legislation. I just want to make that note there. So again, but if you are receiving funding under one of these pieces of legislation and provided domestic violence related services to an individual, then again, a specialized consent form is required unless that disclosure falls under any one of the following statutory exceptions, which we have listed here. The first one is de-identified information for research, duty to warn situations, mandatory reporting, and specific court orders. Now, the other thing to note here is that if you are a covered entity that does not receive funding under any one of those domestic violence pieces of legislation, then use of a specialized consent form is not required. But keep in mind that it is typically a best practice to use a specialized consent form if you have provided someone with domestic violence services, regardless of whether or not you receive funding under said federal legislation. Now, having said all that, let's go over what a specialized consent form entails and where you can find one that meets all of the privacy stipulations associated with that domestic violence legislation that I had listed on the previous slide. So first and foremost, you can see here the first bullet point, it must be written and limited to a specific time and purpose. Secondly, individuals should be fully informed about the form and the timing of any disclosure. And then lastly, you may be asking, well, where do I find one of these forms? Well, fortunately, the National Network to End Domestic Violence has developed a sample client limited release of information form that you can implement into practice. And it's really been designed to meet the federal domestic violence grantee regulations. And it's also available in English and Spanish. And it was specifically designed to address those heightened safety and privacy concerns associated with this population. So with all that, I'm going to be handing over the webinar to my colleague, Christy Avery, to discuss the Altarum created PHI consent tools.
Thank you, Nick. All right. Well, we know that there are state and federal laws that impact what can be shared, when, and with whom. We know that domestic and family violence is something that needs to be taken into consideration. We know that the state has created a consent form, the MDHHS 5515, that can be used for the release of records containing substance use disorder information. And lastly, we've heard about the common instances where consent is not required. Now, how do we determine when consent is needed? Well, we've created this nifty new tool to help you with this very question. And the current version is being housed on the MDHHS's website, and there will be an updated version posted by Thanksgiving, so watch for that. What we've crafted are 2 grids, and these are to help you determine when consent is necessary to share PHI. A general grid spanning several pages that addresses 32 of the most common reasons a request for PHI might be made, and the 5 laws that impact the sharing of that PHI. The general grid is broken down into 3 sections based on the age of the person named in the request, all, which includes both adults and minors, adults alone, and minors alone. The second grid is a very short grid that addresses the domestic and family violence laws that Nick spoke to earlier. The idea is to follow the legislation that gives the most protection to the individual. In order to do this, in addition to following the minimum necessary standard, if the state law says consent is required, but the federal law does not, you must follow the state law. If the federal law says consent is required, but the state does not, you must follow the federal law. If there's no mention of the scenario you're experiencing within the state law, then the federal law must be followed. And lastly, if both state and federal law align or say the same thing, then it makes it all that much easier to know how to respond. Let's take a look at the main page of the general grid. Here you see the reason category all, meaning adults and minors, along with the reasons for request where the outcomes is the same regardless of the age of the person. On this particular page, we have 11 of the 32 reasons PHI might be requested. Next, you'll see the 5 applicable state and federal laws listed across the top: the Michigan Mental Health Code, the Michigan Public Health Code, the Michigan Medical Records Access Act, HIPAA, and Title 42 CFR Part 2. At the bottom of each page, the key of shapes is listed. A red stop sign means that consent is necessary. A green circle means that consent is not necessary. A gray square means that this reason is not addressed by this particular law. A yellow triangle is one of 2 types of caveats, and it means that a clinician may need to use their discretion in releasing PHI. And a purple diamond, the second type of caveat, means that if there is any mention of substance use disorder in the records that are being requested, and the reason for request is not one of the 4 reasons that Mick mentioned earlier, then an individual's consent will be necessary. In terms of the caveats, each yellow triangle and purple diamond have a number listed to the right of them. This corresponds to the specific caveat in the back of the tool. You'll need to reference this in order to understand whether or not consent is necessary based on your current situation. How do you know which of the two grids to consult, the general grid or the domestic family violence grid? Again, if you're part of an organization that receives grant money through SVPSA, VOCA, or VAWA, then you would need to use the domestic family violence grid, and we'll talk more about that in a moment. Most of you will, odds are, end up using the general grid more often than not. So then how do you know which section of the general grid to consult? The age of the person the request is regarding and the reason for the request are the first two important pieces of the puzzle, because this will help you determine which section of the general grid to look at. The next important piece has to do with what type of information might be included in the records being asked for in order to satisfy that request. This will help you to know which legislation to use within the two grids. Does it contain behavioral health information without mention of substance use disorder? Then one would look at the Michigan Mental Health Code and HIPAA. Does it include any mention of substance use disorder? If so, then one would look at the Title 42 CFR Part 2 column, which actually combines the Michigan Mental Health Code with Part 2 and then potentially a caveat listed in the back of the tool. Does it contain details about domestic violence, sexual assault, stalking, etc.? For those federally funded to treat victims, that would require consulting the domestic family violence grid. For those not federally funded to treat victims, well, you would use the general grid. It warrants taking special care not to put that individual in danger by providing the wrong information to the wrong party. So the individual should be spoken with first. And lastly, for those just containing general medical PHI without substance use disorder, behavioral health, or violence-related concerns, one would look at the Michigan Public Health Code and HIPAA. Let's walk through some examples that apply to the general grid, and this will help it make more sense. Example 1. A request comes into your community mental health clinic from the spouse of John Doe, receiving services at the clinic for bipolar disorder. Mr. Doe is not being treated for substance use disorder. Mr. Doe's wife would like to know if he showed up for his appointment, and if so, what his most recent lab work regarding his lithium levels showed. Based on who is asking, the spouse, and for what reason did her husband keep his scheduled appointment, and if so, what did his lab work show? We're looking at behavioral health records alone without substance use disorder. This means that we would consult the Michigan Mental Health Code and the HIPAA columns. You see there's a red stop sign in the Michigan Mental Health column and a yellow triangle in the HIPAA column. A red stop sign means that consent is necessary. A yellow triangle means that a clinician may release the information using their discretion. But remember, we're to follow the law that affords the most protection to the person. The red stop sign is more protective than the yellow triangle. Upon looking at Mr. Doe's record, he does not have his wife listed as his personal representative, and the reason she's asking is not for something eminently urgent or life-threatening that might allow for a clinician to communicate certain information to her despite lack of consent. In order to release the requested information to Mrs. Doe, you would need Mr. Doe's permission. Let's take a look at another example. Example number 2. A care coordinator from an integrated care organization, or ICO, essentially a health plan, talks with a covered adult beneficiary in order to complete a physical health assessment. The ICO must send this assessment to the prepaid inpatient health plan, or PIP, community mental health, for them to perform a behavioral health assessment. The PIP must then send the completed behavioral health assessment back to the ICO for them to create a comprehensive, integrated, person-centered care plan that supports both physical and behavioral health. Based on who is exchanging PHI, an insurance company, and CMH.org in order to create an integrated care plan for an individual, and that's an adult individual. And since this involves general medical PHI and behavioral health PHI and not substance use disorder, the laws that would be consulted would be the Michigan Mental Health Code and the Michigan Public Health Code and HIPAA. You will notice that all three laws show a green circle because consent is not necessary under either state or federal law for treatment or continuity of care. The Michigan Medical Records Act. Why did we include the Michigan Medical Records Access Act? This law serves several purposes, and while it doesn't specifically address more than two reasons on the grid, it gives the individual and their personal representative or representatives a right to access medical records. It specifies a time frame for when records are to be provided, what process needs to be followed if the records in question cannot be located, how long records must be kept, what a reasonable amount to charge for them is, etc. All staff processing medical records should be familiar with this law. All right, let's go on to another example. Example number 3. So what do you do when someone asks for their own records? People are entitled to their own records under the main laws referenced in this tool, and they should be given a copy of their record. That said, let's see what the grid says. Let's say you're an office that provides integrated behavioral health care along with general medical care. An individual requests a copy of a component of their own medical record. They have a behavioral health diagnosis in their problem list, but no mention of substance use disorder. Therefore, we would consult the Michigan Mental Health Code and HIPAA. Both have yellow triangles. At first glance, the symbols are the same and appear to align. That said, one triangle has the number 1 and the other has the number 2 by it, denoting that caveats exist. We need to consult the caveat list in the back of the tool before making a decision to get consent or not. Caveat symbols are the yellow triangles and purple diamonds that denote special circumstances that may need to be taken into consideration. In this case, we have not 1 yellow triangle, but 2. A yellow triangle means that information can be shared if it's in the best interest of the individual. A minimum necessary standard must be used along with what the law calls for. Caveat number 1. Caveat number 1 relates to the Michigan Mental Health Code and whether or not someone has a guardian and or is legally competent, as is sometimes the case with behavioral health clients. If a guardian does not have to be consulted first, then the individual's request should be granted. In each caveat, the orange highlighted legislation appears to be the most protective and therefore should be followed. Caveat number 2. This deals with physical health records, not including behavioral health or substance use disorder. And the 3 pieces of legislation in question all happen to align, but while both caveats appear to align in that they state clinician discretion applies, because the information requested contains behavioral health PHI, and caveat number 1 relates to behavioral health PHI and addresses the possibility of a guardian and competence, it provides greater protection, so it should be followed, not caveat number 2. Let's look at another example. Example number 4. The final example from the main grid has to do with a request that might come in for information on an individual receiving treatment for substance use disorder that falls into the category of performing facility operations. For any requests for facility operations that involve mention of substance use disorder, one must consult the Title 42 CFR Part 2 column that combines that law with the Michigan Mental Health Code in order to facilitate decision making. Here we see a purple diamond and number 8. This is caveat number 8. Purple diamonds. In the legislation grid, purple diamonds mean that the sharing of PHI depends on whether the information requested deals with substance use disorder or substance use disorder treatment. Caveat number 8, when comparing the Michigan Mental Health Code in Title 42 CFR Part 2 The Michigan Mental Health Code provides greater protection because it only allows for de-identified information to be released without consent. Otherwise, consent is necessary. All right, domestic violence. We've mentioned 2 grids, but up until this point, I've only taken you through the general grid. The second grid is the grid that deals with victims of crime, domestic violence, sexual assault, stalking, etc. Organizations that receive federal funding under one or more of these 3 laws need to follow the strict guidelines on what gets shared with whom, as Nick previously mentioned. You will notice that this grid is the opposite of the general grid in that instead of listing all 32 reasons a request might be made and when consent is required, it shows the 5 instances where consent is not necessary and all other reasons require consent for those receiving federal funding through these 3 laws. All right.
We have our last polling question. It is your organization connected to one of the 13 health information exchanges, or HIEs, within the state of Michigan? We'll give everyone a few moments to answer. Thank you, everyone, for your feedback.
All right, so it looks like just a little over half of you are connected. 8% are saying no. We've got not quite a third of you aren't sure, and 3% are saying not applicable. In terms of HIEs, at least 92% of the U.S. population have data shared via health information exchanges, according to a survey completed by the Strategic Health Information Exchange Collaborative that was released just this past August. According to them, more than 200 million patients nationally are served by HIEs connected to the patient-centered data home. And this is the national network that the Strategic Health Information Exchange Collaborative created in 2016 to facilitate exchange of patient information between HIEs. About 70% of hospitals participate in at least one nationwide network, while about half participate in both a nation and a state, regional, or local HIE. This is according to a data brief released late in 2018 by the Office of the National Coordinator for Health Information Technology. And then 38% of hospitals cited leveraging HIEs as a step that they were taking to overcome interoperability challenges in a recent survey of 100 hospitals, IT, and business leaders that was released by the Center for Connected Medicine. All right, so speaking of HIEs, sharing with health information technology. Now that you have a way to determine when consent is necessary, how might you take advantage of technology to increase the sharing of behavioral health PHI for improved care transitions? Leveraging health information technology can be a way to do this. Using the patient portal of your electronic health record allows for several things to happen. It can be a way to collect consent from people. It's a good way for people to have access to their care plans, increasing engagement in that care. Sorry, slide snafu. So again, it's a good way for people to have access to their care plans, increasing engagement in that care. It's also an easy way to provide people access to their health information so that they can download it and or share that information with other people on their care team without needing to request it from you. Under direct messaging functionality of your EHR, that's another way to securely share PHI from one EHR to another. And I don't mean faxing or emailing, but actually sending directly via direct address. In Michigan, we happen to have 13 sub-state health information exchanges, or HIEs, that connect to our main HIE, the Michigan Health Information Network Shared Services, or MIHIN. MIHIN and the Chief Behavioral Health Software here in Michigan, PCE Systems, are in the process of working on an e-consent management process that will allow for sending a query to see if a person has filled out and signed an MDHHS 5515 and where it originated from. I encourage anyone interested in participating in this pilot program to contact Shreya Patel at MyHIN. Thank you, Shreya. Not sharing information, potential impacts. Not sharing information when it's legal to do so impacts patient safety and cost of care. It's also not going unnoticed. Just a few weeks ago, a Florida hospital was fined $85,000 by the Office of Civil Rights for taking 2 years to give a woman the fetal heart monitor test results for her then unborn baby. A consumer website has popped up rating clinicians on how they're sharing PHI. The ratings are based on efforts by its users who've requested that their data be digitally sent to the site, and providers are then scored on a 1 to 5 star scale based on whether response to data requests fit with HIPAA regulations and the Office of Civil Rights right of access guidance. The Office of the National Coordinator for Health Information's latest data brief in September found that 52% of surveyed patients were offered access to their medical records online in 2017. That percentage went down to 51% in 2018. The ONC and CMS released major proposed rules under the 21st Century Cures Act this past February to prevent information blocking that denies access to medical records and spur more use of electronic records. In addition to giving individuals access to patient portals, the ONC wants the industry to make it easier for individuals to use apps to access, view, and subsequently share their online medical record data as a way for individuals to better manage their health and address gaps in interoperability. Also, as a result of the 21st Century Cures Act, CMS will be posting the names of clinicians and organizations that are guilty of information blocking on their wall of shame. Those that are deemed guilty may well be fined up to $1 million per incident, depending on the situation. Other financial ramifications for not sharing data electronically, for instance, not using the patient portal and direct messaging, involve Medicaid clinicians eligible for promoting interoperability incentive dollars missing out on them, Medicare clinicians participating in the Quality Payment Program, or MIPS seeing a decline in Medicare reimbursement based on lower MIPS scores due to not meeting the requirements of the promoting interoperability component. All definitely significant consequences for information blocking on any scale. Okay. So we've hit you with a lot of information in a short period of time. Let's recap. Housed on the MDHHS website lives a brand new consent tool. There are 3 situations when consent is not required to share for behavioral health and general medical PHI, for treatment, payment, and coordination of care / operations. Go back to that Venn diagram slide. There are 5 situations when consent is not necessary for the sharing of substance use disorder PHI, medical emergencies, de-identified information for research, de-identified information for financial audits, de-identified information for program evaluation, and for specific court orders. There are only 5 reasons PHI for domestic and family violence may be shared without consent, and consent for these situations require a different form than the MDHHS 5515. For those instances where consent is necessary for behavioral health and substance use disorder PHI, the MDHHS 5515 consent is structured to contain the necessary pieces of information, and while one is not required to use it if you are not a fee-for-service, managed care, and/or prepaid inpatient health plan, you are required to accept it. If you choose to use another consent form, that form that you do use must have the same components. EHR patient portals, direct messaging, and connectivity to HIEs are all ways to safely and effectively increase sharing of behavioral health PHI, and those blocking the exchange of PHI may end up with negative publicity, fines, and/or lost revenue as a result. Resources. Here is where the resources from today's webinar can be found. All attendees will receive a follow-up evaluation from GoToWebinar that will include a link for the slide deck and recording as well. For those of you interested in the training videos, please sign up for the listserv for notification of their release. And now we move on to questions.
We can now start answering the questions that came in during the presentation. As a reminder, if you have a question for Christy and Nick, please type it into the questions box in your GoToWebinar interface. Nick has our first question.
All right, thank you, Liz. And the first question is from Bob, and Bob asks, do we have to use MDHHS 5515? And so first off, thanks, Bob. I think that is a great question. And it actually happens to be one that MDHHS 5515, or actually, excuse me, MDHHS, the Michigan Department of Health and Human Services, has identified as a FAQ by providers and other organizations regarding 5515. So with that said, MDHHS's stance regarding this question is that you are required to honor 5515 when presented with it, unless you're held to more stringent requirements under federal law, such as receiving funding under any one of those domestic violence pieces of legislation I outlined during the webinar, which again are the Family Violence Prevention and Services Act, the Victims of Crime Act, and the Violence Against Women Act. But keep in mind, however, if you do not receive funding under any one of those federal domestic violence pieces of legislation, you can still use your own consent form or accept other consent forms as long as they're in compliance with federal and state confidentiality laws to share mental health records for purposes, again, other than treatment, payment, and coordination of care. I know that answer is kind of a mouthful, but if you go over to the FAQs on the state's website, you can see, actually, if you Google MDHHS 5515 and you look at the FAQs for providers and organizations regarding MDHHS 5515 and look at question number 5, it will give you pretty much the exact same answer that I just rambled off. So, all right. Let's see. We have another question here, and this one is from Daria. And Daria asks, why did you combine the Michigan Mental Health Code and Part 2 for SUD records? Again, that is another great question, and thank you, Daria. So to answer this question, I'm going to start by rehashing something I said during the presentation portion of the webinar when I briefly covered substance use disorder legislation. So that is, in the state of Michigan, if you are a licensed covered entity providing SUD services, then chances are you're regulated by both Chapter 2A of the Michigan Mental Health Code and Part 2. So given that general alignment between Chapter 2A of the Michigan Mental Health Code and Part 2, the Altarum team then attempted to really simplify and condense information regarding the sharing of SUD records by combining both state and federal legislation, I believe, within the column that you're referring to within the tool. Okay, I want to make sure we get as many questions as we can in here. The next one that we have, Christy, do you want to take this one?
Sure.
Okay. The third one here is from Heather, and Heather asks, how do I know if my office is funded under those domestic violence laws?
Thank you, Heather. The short answer is that you would want to check with your administration or leadership team to know for certain. Generally, organizations that do counseling, referrals, development of safety plans, advocacy, legal advocacy, and other services for victims of violence and/or provide comprehensive services to Michigan crime victims, including compensation for injury, counseling, victim advocacy through the Office of the Prosecutor, victim rights services, and victim notification through the MyVine, then you might be receiving funds from either FVPSA or VOCA. Technically, no one is currently being funded under the Violence Against Women Act because as a result of the government shutdown at the beginning of this year, VAWA expired. It was temporarily reinstated for by a short-term spending bill in January, but it expired again in February. The House of Representatives passed a bill reauthorizing it in April, and it includes new provisions protecting transgender victims and banning individuals convicted of domestic abuse from purchasing firearms, but it's been ignored by the Senate. If this funding does not eventually renew, we will change the grid accordingly.
All right. Thank you, Christy. The next question we have is from Michelle, and she asks, if we have SUD records for a patient that we got from another office and the patient goes to see a specialist, do we have to get their consent to share the SUD records?
Thank you, Michelle. That's a good question. This would fall under what's known as redisclosure. Redisclosure is when you share records from another facility not created by you. You are not allowed to forward substance use disorder records that you receive from outside of your organization to another entity without the permission of the individual in question, even if it's for continuity of care. When you share information that was created by your organization with an individual's permission, you are supposed to use what's called a redisclosure notice. You can find verbiage for what a redisclosure notice might need to include in the glossary of regulatory terms and in that section in the PHI tool. And I believe it's under the Title 42 CFR Part 2 redisclosure notice language.
I am just going to interject really quickly. We do have a ton of questions. We're going to try to get to as many of them as we can. And we recognize that we are getting quite a few legislation-based questions. To enable us to give you an adequate answer to these, we're going to respond to those legislation-based questions through email to you in a timely fashion. And just as a reminder, today's presenters are not attorneys, nor is the PHI consent tool to be used as legal advice, but we will address everybody's questions. Also, we do encourage listeners to seek out their organization's own legal counsel in regard to any kind of sharing of PHI. Nick has a few more questions.
All right, thank you, Liz, and thank you, Christy. So we have a question here from Sibley, and I was actually expecting this question to come up too. And she asks, could you help me better understand what it means to be regulated by Part 2? So again, thank you for asking that, Sibley. And Part 2 is very nuanced. So that's, again, I was expecting that kind of question, and it's one that we often run across. So with that said, it's important to highlight the applicability of Part 2 for this question. And I'll start by saying that Part 2 regulations do not apply to every record maintained by any healthcare provider that shows that an individual has a SUD or SUDS. Instead, in order for Part 2 to be applicable to a SUD record, 3 requirements need to be met. So first, the record must identify the individual as having or having had a SUD either directly by reference to publicly available information or through verification of such identification by another person. Second, the SUD record must have been obtained by a program, and I put program in quotations. And then third, the program must be federally assisted, and I also, I'm putting federally assisted in quotations there. So with that said, the first requirement that I listed off is relatively straightforward, but I believe the remaining 2 warrant further explanation. So in order to meet the terms of the second requirement and qualify as a program, an individual or entity must either hold itself out as providing SUD services or have an identified unit that holds itself out as providing such services. Additionally, a Part 2 program includes medical personnel or staff in a general medical facility. And if such staff's primary function is the provision of substance use disorder diagnosis, treatment, or referral for treatment, and is identified as such a specialized medical personnel or other staff within that general medical facility. That's important to note, and it helps with identifying whether Part 2 applies. And the other thing to keep in mind here too is that general medical facilities may include hospitals, FQHCs, and physician practices. Also, SAMHSA, the federal agency that's responsible for administrating Part 2, has provided some guidance by what it means when an individual or entity holds itself out as providing SUD services. And I'd be happy to share that SAMHSA information about that hold itself out language. So if you want to have more information about that hold itself out language, please feel free to send us a follow-up email, and I can elaborate on that. But then lastly, the definition of federal assistance is important, and it's actually quite broad. So a program is federally assisted if, among other things, it participates in Medicare or Medicaid and is paid claims under those programs, receives any other type of federal funding, is tax exempt, or maintains a drug enforcement agency or DEA registration. So therefore, let's conclude this question of whether or not Part 2, or if you're regulated by Part 2, or what it means to be regulated by Part 2 by a hypothetical here. So let's say, or really any clinic or practice seeing Medicaid or Medicare patients, meaning that they receive federal funding for their care, would be subject to regulation under Part 2 if they met the first requirement, which is identifying individuals as having SUDs, and also the second requirement, which is to hold themselves out as a SUD provider. Okay, so I will make sure to stop there so we can also answer some more questions before our time is up. But again, please feel free to email us with any questions, or if you simply just want to have a discussion about all this. All right, so let's go on to Kathleen. And Kathleen asks, could you please explain the difference between the two caveats, the yellow and the purple ones?
I'll take that, Nick. Yeah, thank you, Kathleen. A yellow triangle means that the law allows for sharing of PHI if it's in the best interest of the individual, and again, you're looking at making sure you're using the minimum necessary standard and also what the law calls for. It essentially means a clinician can or may need to use their judgment depending on the situation. Purple diamonds mean that sharing PHI depends on whether the information requested deals with substance use disorder or substance use disorder treatment, so it solely relates to records that contain mention of substance use disorder.
All right, thank you, Christy. And it looks like this might be the last question that we have time for. And this question comes from Anita, and she asks, for mental health records, can the holder of the record withhold sharing information to the subject of the mental health record if they believe it's reasonable to prevent physical harm? Well, that's a great question, Anita, and it's actually one that we admittedly had spent some time discussing internally. And overall, really, the answer is that it depends. And if you look at caveat number 1 within the tool, that provides some helpful guidance to this question. And I'll restate that here, which is that if the adult individual does not have a guardian and has not been adjudicated legally incompetent, Section 330.1748.4 of the Michigan Mental Health Code mandates disclosure of mental health records to that adult individual upon that individual's request. And the holder of that record shall comply with the adult individual's request for disclosure as expeditiously as possible, but in no event later than earlier of 30 days after the receipt of the request, or if the recipient is receiving treatment from the holder of the record before the recipient is released from treatment. However, if the individual is a minor or has a guardian appointed, then the Michigan Mental Health Code permits withholding all or part of the mental health record if such disclosure is detrimental to the individual or others, and that's specifically in section reference 330, 1748, 6B of the Michigan Mental Health Code. All right.
So we know we are over our time today. Thank you everyone for staying with us. We know that we have not answered all of the questions. Thank you everyone for everything you have submitted. If we did not address yours, you will receive an answer through email. Also, you will be receiving a link to a post-webinar survey. We would really appreciate you taking the time to send us your feedback. The slides from today's presentation and a link to this recording will also be available soon on our MCEDA website at www.mceda.org/webinars. If you have any questions regarding specific legislation, you may submit them through our online form at bit.ly/mi_consent_help. If you have more questions about the PHI consent tool, you can email them to Christy and Nick at mi.consent.help@alterum.org. Thank you everyone for attending and have a great day.